We'll be speaking about best practices for implementation of renal denervation in clinical care. So I'll basically talk about the principle, the product, the position, the guidelines. Why do we need RDN? The product, how do we do the procedure? Similar things as we've been discussing, clinical performance, my experience with RDN, because RDN was recently introduced in India, patient selection and counseling. And yes, we know that RDN disconnects the sympathetic signals, and so the inappropriately increased sympathetic signaling which is occurring, that is reduced by it, and consequently, so the blood pressure is reduced. We've had clinical practice, guidelines, position papers, and consensus statements, and RDN publications have been published in multiple countries. So right from 2018 to now 2024, we're looking at a host of guidelines. What is important for us in India is that in India, we are recently been introduced with the spiral system, and we are offering it to patients with resistant hypertension in our country. But in a lot of countries, for example, the Taiwan Society, they have also approved it for borderline hypertensives, for people who are non-compliant, for people who are non-adherent, for people who are having side effects. But for us in India, we're giving it to patients who have resistant hypertension. There's been a lot of clinical evidence, there's been a lot of research, there's been a lot of innovation, and a lot of experience from a lot of operators all over the world. Yes, 2 different modalities are currently commercially available. However, in India, we don't have the ultrasound device as yet. We only have the spiral system. And there's also one under development, as we were discussing about the alcohol system. So we have trials way back from 2009 when they did the Simplicity Hypertension 1, and then followed up with the sham trials, and then we had the spiral trials. And then of course we had the Radiance trials, and then we are having trials on the alcohol-mediated renal denervation. The Simplicity Spiral Renal Denervation System available in India has the largest experience of greater than 4,000 patients in a global clinical program, and greater than 7,000 patients in peer-reviewed research, and greater than 25,000 patients treated globally. It has global approvals in almost 60 countries around the world. Southeast Asia, a lot of the countries, including India, Europe, Australia, USA, and China. Recently in 2023, in Japan is under progress. So why RDN? The need. The need is because hypertension is an Indian health crisis. And yes, we know that uncontrolled hypertension is going to increase the risk of heart attack, heart failure, stroke, and kidney failure. And 1 in 4 men and 1 in 5 women are suffering from hypertension. And even when you treat them, 53% of treated hypertension patients do not have their blood pressure under control. So we are looking at treatment-resistant hypertension, we're looking at non-adherence, intolerance, and we are also aware of the fact that as the number of pills go up, the pill burden goes up, the number of people who are non-adherent, it also goes up significantly. And in fact, non-adherence was observed in over 40% of patients who were taking antihypertensive medications, and we are looking at a lifelong antihypertensive medication. So, how are we going to help them? How are we going to help this huge population of hypertensive patients is the question, and that's what has triggered all of this research and all of this work in this segment. And it is, hypertension is a leading preventable cause of heart attack, stroke, and death. And just reducing the blood pressure by 10 millimeter would lead to clinically significant, meaningful reduction in cardiovascular events, to the tune of a 20% reduction in relative risk of MACE and a 13% reduction in relative risk of all-cause mortality is what we are looking at. So this is the product. This is the Simplicity Spiral Renal Denervation System. It utilizes a helical electrode pattern to ablate all 4 vessel quadrants simultaneously. It's very versatile. There's only one catheter. You don't need different balloons as in the Record system, different sizes. You have one catheter, one size fits all, and you ablate all vessels between the size of 3 to 8 millimeter in diameter. Very simple, easy to use. It's just a plug-in device. So you would just plug it into the Simplicity G3 radio frequency generator, and this generator automatically monitors and safely controls the power to each electrode independently. What that means is that if you have an inappropriate rise in the temperature or change in the impedance, it will automatically deselect that electrode. So there are 4 electrodes at 5 millimeter distance each. And if any electrode is showing the wrong parameters, it will deselect it, it would switch it off. So that's very good for patient safety. The procedure, typically the procedure is conducted, the procedural strategy is to reflect the renal nerve anatomy. The distal nerves are closer to the arterial lumen. 63% of the kidneys had renal nerves that join distal to the main renal artery bifurcation, the late arriving nerves. And greater than 30% of cadavers had highly innervated accessory arteries. This is important to know, because initially when they started RDN with the flex catheter, they were ablating the main renal arteries. And then they realized that that was not the right thing to do because of the innervation pattern of the renal nerves was more distally. And that's when they started ablating the distal renal arteries, and they went into the branches. And also because 30% had accessory renal arteries, which also had a role in the hypertension. So they started targeting the accessory renals too. This is a combined branch and main artery treatment as of today, which results in greater and more consistent preclinical effect. Previous treatment, as I said, had only focused solely on the main body of the renal arteries. And the IV study actually demonstrated a statistically greater and more consistent treatment effect when both the main renal artery and the branches were ablated as compared to only the main renal artery. This is the catheter and this is the procedure. So it has a very unique design because it's a spiral. The moment you pull out the extra support wire, it will go into a spiral shape. So it automatically positions the electrodes to generate 360-degree ablations. It's very consistent. It's a repeatable 4-quadrant ablation pattern. You only deliver energy for about 60 seconds, and the temperature and the impedance feedback to control the energy delivery. Again, it's delivered to the renal nerve through the artery wall, preferentially heating the perivascular adipose tissue. Vessel diameter, I've already said, you only do it in vessels which are of the size of 3 to 8. It's very convenient to use because you only use a 6 French guide catheter compatible and a rapid exchange delivery. The clinical performance, yes, there have been a host of studies which were sponsored by Medtronic, and many of them are committed to RDN, and they continue to lead the field in this thing, starting right back from the hypertension 1, 2, 3. And then the clinical trial was redesigned, and then they had the spiral hypertension off and on med, and they have the global simplicity registry and the GSR defined. And we are seeing a lot of benefit, again, in the absence of medications, in the presence of medications, it's all being tied. What is so important in RDN is that these patients have an always-on effect over 24-hour BP lowering. So even if the patient forgot to take his medication, the always-on effect of RDN remains, and that's important. And over the years, in many of these studies, they've seen that the graph is actually widening. So many of the patients don't have an immediate effect. They might have a delayed effect, but over years, the effect comes on. So it's very important to have patience in these patients. Again, whenever we talk about a therapy which comes in, we have to talk about the safety profile of it. And we were just discussing, is it safe? Yes, it's been shown to be very safe. And it has minimal impact on the renal function and the vascular safety events. It's been evaluated across major clinical programs and independent meta-analysis, and has shown renal safety. So there were 0 cent implants reported in over 700 simplicity spiral patients, and the kidney functions generally remained stable. There was a minimal decline in the eGFR through 3 years in the Medtronic GSR study. What about reinnervation? So whenever we deliver this and we do a renal denervation, there's always a question in our minds. Is the sympathetic nerve activity going to come back? Is this a permanent destruction, or is this patient going to need a repeat procedure? So they've done studies in which they've seen that there was unrecoverable sympathetic nerve activity after radiofrequency RDN. They found that there was permanent axonal destruction, sustained reduction in renal norepinephrine, and then they did a renal nerve viability assessment, and they found that there was sustained destruction. However, we have limited data to a limited number of years. We are not completely sure that will there be reinnervation or not. Again, sustained BP reduction up to 3 years and beyond in over 3,200 patients. So the durability, the procedure is durable. For those in whom it works, it's a durable procedure. And again, beyond 3 years, they also have data in some countries up to 9 years. My experience at Apollo Hospital Indore, so in India it only became available about a year ago, but about 3 years ago when we didn't have this device available, and this was actually our first case which made us believe in it, because this was a patient who was relatively young, 56 years, and recurrent episodes of tingling numbness, right? He was having TIAs. He was referred to us for control of blood pressure. He'd already had a CVA earlier. His blood pressure was 180, 110 on multiple antihypertensives. We did all his checks, checked his compliance, and hiked up his medication. His prescription looked like this. And this gentleman was in trouble. So we offered him RDN on compassionate grounds. We got it imported to India from Singapore, and then we did an RDN for him. Typically how we did this procedure, because the spiral is a stiff catheter, we normally take a workhorse wire, exchange with a micro catheter, put in a Grand Slam wire after that, and then we take the Simplicity spiral in. Then you pull back the Grand Slam, takes its spiral shape, and you can go ahead and deliver the energy. We went distal to proximal. We took a final shot at the end to rule out any perforation or any dissection. And currently, this patient, after 3 years, is on 3 antihypertensives with control of blood pressure. That was the time we started believing in this procedure. So he was clearly a hyper-responder. Most patients don't respond like this. Most patients, you may be able to reduce maybe one medication, or you may be getting a better control of blood pressure. And of course, 20% of the patients don't respond because blood pressure is a multifactorial thing. It's not just a sympathetic stimulation. Patient selection, guideline recommendation, other considerations are very important. Yes, it can be offered as a treatment option to patients with an eGFR greater than 40 who have uncontrolled blood pressure despite the use of antihypertensive drug combination therapy if the drug treatment elicits serious side effects or poor quality of life. It's also important to rule out secondary hypertension, and other practical considerations are also important. At present time, there's a question which hits all of our minds. Who are the patients who are going to be responders? Well, we don't really know, but baseline BP has been found to be a strongest predictor of BP response to RDN. The higher is your baseline BP, the chances are that this patient will respond. Also, the higher is your baseline heart rate. A lot of people have seen that higher is your baseline heart rate, the chances are these patients will respond. Patient counseling is essential in this procedure. It's important to tell them that this time response can vary from patient to patient. You can have hyper-responders, you can have non-responders, and you can have delayed responders. So it's important to tell them upfront, this is a therapy which is not a magic, but it will take time, but it may give you a good result. Also, you might be a non-responder too. A 1 month or even a 3 month follow-up is an appropriate time to judge the response. Clinical trials have suggested a sustained drop in progressive decline in the blood pressure. Again, it can be found to be reducing later at follow-ups. Patient must also record home blood pressure and regularly follow up post-procedure. It's important that a precise set of standard operating procedure is available so as to adhere to safety and ensure the performance. And it's not advisable to change the drug regimen immediately after the procedure. You have to keep following up with the patient's blood pressure, also put him on an ambulatory blood pressure monitoring, and then do the right thing. We still need answers in RDN. A lot of things, a lot of questions in our mind we've been discussing right now. And can it cure hypertension in the borderline hypertensive? A lot of people who are borderline hypertensives who don't want to end up taking medication for the rest of their lives, they would come to you and ask whether it's possible for them. Can it reduce the need of antihypertensive medication? Yes, probably one medication it's equivalent to, and it can reduce. Will it work in patients with only isolated systolic hypertension? And can we decide upfront who are the responders? Who are the patients who are going to respond so that we can offer it selectively to them? We have soft points at which we look at, but none of them has been absolutely substantiated that this patient is a responder. We still don't know that. What about the durability? Will this patient require a repeat procedure? We have data from some countries, 3 years up to 9 years data, but we don't know exactly if this patient would require a repeat procedure in his lifetime. Can it be an option for patients who don't want to take medication? At present in India, no. How does it compare with the ultrasound? We have a single trial, that is the radio sound, which we were just discussing, but we need more data about that. And what is the endpoint of denervation? So when you're in the cath lab and you're denervating this patient, and you want to know when to stop, there's no endpoint over there. You just have to selectively go into every branch which is outside the renal shadow and every accessory and ablate all the points and stop when you're done. There's no endpoint in the cath lab at present. So ladies and gentlemen, thank you so much.